Hello, my name is Christina Wetzler and I am a speech and language pathologist working at Totally Kids Rehabilitation Hospital in Loma Linda, California. With my two colleagues, Taryn Lozon and Haley Garcia, we are bringing this video to you to demonstrate numerous difficulties we observe when we are trying to help newborn infants learn to feed with a bottle. Most newborns quickly learn to suck and swallow, but for some infants, acquiring the natural skills of oral feeding is challenging. As we demonstrate these difficulties, we will introduce you to our evaluation using the Totally Kids Infant Feeding Scale. At Totally Kids Rehabilitation Hospital, many newborn infants are admitted directly from the neonatal ICU. These infants are developmentally delayed because of various medical problems or because they were born prematurely, and almost all have difficulty feeding orally with a bottle. They are transferred to our hospital into a special program designed to facilitate their development, and an important goal of the program is to help the infant transition from tube feeding to oral feeding with a bottle. From observing many infants as they have struggled to achieve safe oral feeding, we have noticed that these infants show several distinct difficulties that may interfere with their attempts to feed. From these observations, we have devised a system of evaluation of an infant attempting to bottle feed by grouping these difficulties into 6 separate categories. These categories are all identified by direct observation and are oral acceptance, taste or flavor acceptance, oral strength or sucking, respiratory coordination, self-regulation, feeding proficiency. For some infants, these difficulties may be minor, but for others, the difficulties may be much more severe. We have found it helpful to use a numerical scale to rate the severity of each of these categories on a scale from 1 to 5. We are pleased to share with you the features of the Totally Kids Infant Feeding Scale. In this video, we will show you infants being bottle fed and demonstrating each of these categories of feeding difficulty. We will also explain how to arrive at a score to rate the severity of the difficulty in each category.
We've been showing you a normal infant feeding. Now let me show you what to look for before feeding an infant. We use the pre-feeding checklist to assess the infant's readiness to feed. We do this to ensure the infant is in an optimal state to safely and effectively participate in feeding. The checklist incorporates many of the items that are necessary to ensure a successful feeding. Before entering the infant's room, we review the basic information and document this on the pre-feeding checklist. The feeder should note the scheduled feeding time, the time of the feeding evaluation, the time and amount of the infant's previous feeding, the need for gavage support, the prescribed amount of milk, and the initial nipple and bottle recommendation. If there is not a recommendation for nipple flow, we suggest starting with a slow flow nipple. Once we are familiar with this information, we are ready to assess the infant's initial state and the hunger cues. Here is an infant who is not demonstrating she is ready to participate in a feeding. The infant is asleep and is not showing us any cues that she is interested in feeding at this time. Before attempting to bottle feed an infant, we must be sure that the infant is awake, alert, hungry, and ready to be fed. Within a hospital setting, we must utilize schedules for feedings and medications. However, for oral feedings, we want to make sure the infant is demonstrating proper hunger cues in order to provide an optimal feeding experience. In contrast, here is an infant who is clearly showing us that she is hungry. The infant is awake, looking around the room, and sucking on her fingers. This is a great time to begin our feeding evaluation.
Before beginning the feeding, we want to specifically look at the child's ability to tolerate tactile input. Here's an infant who appears to be hungry and ready to be fed. Although this infant is hungry, he is turning away as soon as we approach him with the pacifier. The infant is crying and grimacing with the introduction of non-nutritive stimulation, including playful touch to the mouth and lips. This infant is not yet ready to accept the bottle and is demonstrating what we call tactile aversion. The level of aversion can range from profound, resulting in little to no oral input, or it can be minimal, requiring just a little assistance to participate in the feeding. Here is an example of an infant who is demonstrating optimal level of tactile acceptance. This infant is smiling, making eye contact, responding positively to the interaction. This infant is actively sucking on their pacifier and is ready to attempt bottle feeding. As we begin to introduce the bottle, it's important to note the difference between how an infant responds to touch or tactile acceptance compared to the introduction of milk. This is what we consider taste or flavor acceptance. Most infants will transition smoothly from a pacifier to a bottle. However, this infant is demonstrating some negative responses to the introduction of the liquid. This infant was content with a pacifier and playful touch to her face, but now that we've added the formula, she's crying and turning away from the bottle. We can see that this infant already has an elevated heart rate and respiratory rate as a result of the introduction of the bottle. If we try to continue to feed this baby, who is already demonstrating an aversion to the formula, she may begin to cough, gag, or even throw up. In order to prevent further aversion, we will give this infant a break from feeding for now.
Once an infant demonstrates acceptance of the bottle, we begin to look at his or her oral strength. There are many factors involved in an infant safely and effectively feeding, and some of these are related to the infant's strength. As we assess the infant's strength, we examine his or her latch or seal around the nipple and the amount of spillage of liquid throughout the feeding. We also consider the infant's need for supportive adaptations, including chin and cheek support. This infant has a weak latch around the nipple, as we can see by how easily the nipple can be removed from their mouth. Because the infant's latch is so weak, much of the liquid is spilled while they are feeding. After seeing these signs of weakness, we can add in a supportive adaptation. I will now provide the infant with chin support by placing my finger lightly under his or her chin. This will provide the infant with a base of support during feeding. Another option at this point would be cheek support. For this, I would provide light support to the infant's cheek using 1 or 2 fingers, depending on the infant's need. Although this can be a useful adaptation to help the infant initially achieve an improved latch or seal, we must be careful to not overwhelm the infant by increasing the flow of milk, as this can be unsafe. An effective use of chin or cheek support would be to provide a gentle base of support initially and to facilitate endurance for feeding. When thinking about the use of chin or cheek support, we are simply assisting the infant in completing the task of feeding. For example, an infant who is demonstrating signs of fatigue throughout a feeding can be noticed by a therapist. The therapist can assist the infant in completing the task by providing light chin support. If the intervention is successful, we'll notice the infant continue with a strong, coordinated sucking pattern while maintaining a regulated state. However, if the intervention is not successful, we may notice the infant has increased difficulty with managing the milk and maintaining coordination of his or her suck, swallow, breathe pattern. It is important to read the infant's cues while utilizing this intervention. This infant is showing great strength for oral feeding. He has a tight latch around the nipple and it cannot be easily removed. There is very minimal spillage of milk while this infant is feeding because his or her oral motor skills are so strong. This infant won't need support from us to finish their bottle.
Infants must not only have the strength for feeding, they must have the respiratory support and coordination. Breathing is the most basic physiologic function, and an infant cannot feed unless he or she can breathe. To safely feed, an infant must also be able to maintain a synchronized, rhythmic, suck, swallow, breathe pattern. This means the infant must first retrieve the liquid by sucking, then completely swallow that liquid, and then take a breath to complete the sequence before beginning again. The infant must maintain this rhythmic pattern of suck, swallow, breathe throughout the entire feeding. This is vital to the infant's safety. If there is a disruption in this pattern, the infant is at risk for aspiration, which is when food or liquid enters the airway instead of the stomach. For example, the infant retrieves the liquid but then takes a breath before swallowing the liquid, creating a high risk for aspiration. The infant we are currently feeding is showing us what a coordinated suck, swallow, breathe pattern looks like. We can see the infant is completing a more mature sucking pattern with around 10 sucks per burst, safely swallowing the liquid and then taking a break to catch his or her breath before resuming the pattern. This infant is maintaining a coordinated pattern throughout the entire feeding without breaking his or her latch. Not all infants demonstrate the same coordination and endurance as this infant. An infant with difficulty in their suck, swallow, breathe pattern will often show us signs of respiratory distress, ranging from severe distress to very mild. We might see an infant with physiologic changes like increased respiratory rate or heart rate, or decreased oxygen saturations. An infant may also present with more mild signs such as hiccuping or increased limb movement. If the feeder starts to notice any of these signs, they should immediately address them to ensure a safe feeding. We can also provide adaptations to assist an infant with difficulty managing this pattern. Most frequently, we use external pacing to help the infant safely coordinate his or her suck, swallow, breathe pattern. By using external pacing, we can control the number of sucks per burst and ensure the infant is taking breaks to regain their respiratory control. A simple way to provide external pacing is by tipping the bottle down or back to simply stop the flow of milk. In extreme circumstances, we can completely remove the nipple from the infant's mouth. We only completely remove the bottle if we absolutely have to, as this can be very disruptive to the infant's feeding pattern. External pacing is necessary until an infant gains the skills to independently pace themselves for an entire feeding.
Typical infants are able to regulate their own physiological and behavioral responses during feeding opportunities in order to safely and effectively participate in feeding. Infants born prematurely or with medical complexities have much more difficult time regulating themselves, especially during a feeding. Infants with these difficulties may do much better with the assistance of a trained therapist who is able to utilize specific adaptations. It's important that the infant not be distracted by overstimulation from their environment so they can successfully focus on the skills needed for feeding. While most infants are able to tolerate an active feeding environment, the infants who are born prematurely with an undeveloped sensory system will require adjustments to the feeding environment. When we evaluate self-regulation of the infant, we pay attention to the number of adaptations the infant requires to become regulated, as well as the amount of time throughout the feeding session that the adaptations are necessary. Here, we have an infant who is showing clear signs of dysregulation. The infant is moving her arms and legs, turning her head away, crying, and is not at an appropriate state to be fed. When an infant is presenting this way, we can assist the infant by applying the needed adaptations. Our therapist is providing the necessary calming strategies of rocking the baby, providing an appropriate auditory input, adjusting the lighting, and is maintaining an overall quiet and calm feeding environment. Although the infant has become better regulated with these adaptations, she still may require further assistance to reach her optimal feeding performance. Since the infant is still actively moving, the therapist will provide deep proprioceptive input by swaddling the infant with her hands at midline, close to her body and her face, in order to help her soothe. It's important to continuously read the infant's cues throughout the feeding to add or take away adaptations as needed. Sometimes an infant will only need these adaptations for a short period of time, while other infants will require the adaptations for the entire feeding. It's also important to note that for some infants, the difficulty may be a low level of arousal or alertness, and our adaptations will focus on increasing the baby's ability to regulate the environment in order to participate in a safe and satisfactory feeding session.
The category of proficiency refers to the volume fed during 30 minutes as the percentage of total volume prescribed. Before we start feeding an infant, we always check the amount of milk in the bottle to find the basis for calculation. We also note the time that the infant starts actively feeding because we need to monitor the duration of the feed. At the conclusion of the feeding, the therapist must check the remaining volume of the milk in the bottle to calculate the infant's total intake. By tracking the infant's proficiency, we can have a better understanding of the infant's endurance for feeding. For example, if an infant is only able to tolerate a small amount of the prescribed amount of milk, we expect they will require supplemental nutrition through gavage feeding to maintain normal growth and brain development.
Following the feeding, it's very important to have effective communication with the feeding team, including the bedside nurse, other therapists, family, and everyone else involved in the care of this infant. At our facility, formal orders are written with the recommended bottle, nipple, position, and adaptations for each infant, and these are followed by everyone who feeds the infant. Another way to communicate and promote consistency is by utilizing a fact sheet or a sign near bedside indicating the personalized feeding recommendations for the infant. It is also important to give a detailed explanation describing the why behind each recommendation. This helps to maximize carryover with the family and the caregivers. It is essential that everyone on the feeding team is on the same page and follows the best plan for the infant. Some of the important feeding recommendations to communicate to the team include the bottle and nipple positioning, pacing requirements, and necessary environmental adaptations. As you can see throughout the videos, we most frequently utilize a side-lying or elevated side-lying position during evaluation to promote consistency and safety.
Infant feeding is a very complex process, especially with premature infants and those with delayed development. There are many factors to consider when determining the best plan of treatment for each infant. By utilizing the categories outlined in the video, you are able to assess and monitor the full picture of an infant's feeding abilities and provide a quantitative measure of the severity of their feeding difficulties. Infant feeding difficulties can often be subjective, and our hope is that the Totally Kids Infant Feeding Scale will help to create a more clear and defined approach to assessment.